All right, good morning, everyone, and welcome to the latest install of weekly NB Heart Center CV rounds. This is an exciting moment for us to be able to welcome Dr. Greg Hirsch from Halifax at the QE2 Health Sciences Center. Greg is well known to many of us, but for those of you who don't know him, he has actually been a cardiac surgeon at the QE2 Health Sciences Center since 1994. And he, since 1995, and he was actually division head of the program between 2004 and 2017. Some of you may also know him from his capacity as a researcher. He's spent a lot of time functioning both as a translational basic scientist, as well as a clinical outcomes researcher in the field of cardiovascular care, and more specifically cardiac surgery. He also spent time as a quality director for the Department of Surgery and is currently in that role and has been since 2015. And now also since 2018 has served as the senior director for perioperative care as part of the provincial network. So I think really from my standpoint, my relationship with Greg started as a resident when I was in Halifax. He really took me under his wing from a research standpoint when I started up my PhD. And between his clinical and his academic mentorship, I really owe him a lot. And a lot of who I am today is based on his example that he set for me. So it's a real pleasure to have Greg join us this morning and really to speak on an area that he's quite fond of and currently doing a lot of active research in, which is the whole role of cognitive and physical frailty in patients who are undergoing cardiac procedures. And I thought a good idea of kind of spinning this in a way that would be of interest to all of us is, when we see these patients and we consider these issues, when do we actually say no to these patients? Or better yet, when do we, with our patients, say what is the best option for us? So without further ado, I'll pass it over to Greg.
Thanks for that generous introduction, Ansar, and maybe worth noting, I also had a small role to play in Dr. Laguerre's research education and his clinical education, which I'm very proud of. Really welcome any opportunity to talk about frailty and talk about shared decision making. And I think it's worth noting for this audience that may not be aware, you and I have been actively collaborating, and our two centers, thanks to JF's cooperation and leadership, have been sharing grant support and doing maritime-wide research in this area, looking at barriers to implementing what we're going to talk about today. So we'll start with a case: an 87-year-old male with ischemic heart disease and aortic stenosis. The CAD, for argument's sake, is not amenable to PCI. I know Osama Al-Khatib would correct me because all CAD is amenable to PCI. And an aortic valve area of 0.7 centimeters squared. He has CFS, it's a clinical frailty scale level 4 to 5, mild memory impairment, mobility limited by breathlessness, independent in his activities of daily living. He used to garden and interact regularly with his neighbors, but not last summer. He's hypertensive diabetic and has a CKD with an A1C of 9% and a creatinine of 150. And his goal, when you spend some time talking to him, is to get back to the garden, and he's willing to risk survival. But he wants care limits if his independence is in any significant question. So he doesn't want to slip to below where he is, which is a tricky proposition, but he's really willing to gamble to get back to better functional capacity. So we were the first, I'm proud to say, and way back in 2010 to show that frailty, rather crudely measured by the CATS index, had a bad effect on cardiac surgery outcomes. You could say, well, duh, but it managed to get a CIRC publication. The CATS index is a defect in the activities of daily living, and that's going to come back in my later research to be really a fortuitous guess at where to focus our definition of frailty. We also added to it a significant defect in ambulation of using at least a walker, or documented dementia. And in that research study, using our database where we're collecting this, and I'd urge us all to make some effort to collect frailty, we showed a significant negative impact on mortality, but more importantly, on prolonged institutional care, which meant unable to be discharged home from hospital. That's a soft indicator of prolonged dependence on care, but it's all we had to work with. And for sure, those who can't go home immediately are at increased risk for prolonged functional deficits. And that OR, that odds ratio was 6.4, which is, of course, very strong. And here's another way to show unadjusted outcomes as impacted by frailty. And this was any CATS positive or any mobility or any dementia. It wasn't dose dependent. We just took one and the effect size was large at 1. Had a negative impact on mortality, on a combination mortality and complications of long ICU stay and of discharge to an institution. And this is just a more detailed look. The tricky parts of this, and we don't have time today to talk about how you disarticulate age from frailty. It is hard. And we use the cubic spline approach, which I'd be happy to share with you if I understood it better, but I could find people who understand it well enough to share it with you. And the same for the prolonged institutional care odds ratio of 6.3, and that outweighed all others. We're not the only ones to have shown this at this point, and importantly, other scales can be used. This is the Edmonton Frail Scale, showing improved prediction over Euroscore on even mild and moderate frailty on a prediction of mortality. And this is a tool we've come to use more recently. I am not a zealot for a particular tool, but I do think if groups are going to work together, and if, recent work that both JF and ANSA are supporting with the Canadian Society of Cardiac Surgery, maybe get us all onto one tool just for comparison's sake. But this is the fact, the frailty assessment and care planning tool, and I like it. It's homegrown. It's developed by Paige Morehouse and others at Dal. Is that it has multiple dimensions of frailty measured, mobility, social functioning. There's those daily tasks again. The ADLs come back in, and a memory cognitive aspect. The memory cognitive aspect requires interaction with a researcher. The first 3 can be self-administered in a clinic, so it's appealing that way. In that, patients have more time than doctors. They're often waiting for us and their family members, so they can fill these out and give you some aspect of frailty. And a previous graduate student, Emma Wilson Pease, who's now moved on to Ottawa, did a nice piece of work, really mirroring the one slide I showed you using the Edmonton Frail Scale that shows that the FACT tool predicted mortality in MACE and predicted it better than Euroscore 2. And the important takeaways here, and it'll take a minute to talk about it, is that mobility, I don't know if my pointer shows up, mobility was not a significant predictor. And that kind of makes sense because at least some of what we do as interveners in cardiac disease, whether it's in the cath lab or in the operating room, is designed to improve mobility, right? And this, remember, our man is frail because of mobility issues, and he has TAD and aortic stenosis, and so he has good reason to be functional class 3, short of breath, and it limits his gardening ability. That is actually logically going to get better if you take care of those 2 problems. Other mobility issues, of course, wouldn't be, but as a result of it being positively impacted by the surgery itself, it fails to, this is my guess, it fails to be a significant predictor of adverse outcomes. I think if you did hip replacement, you get the same signal, right? Those people would be mobility frail, but logically able to get better. Social function, however, daily tasks, which has the highest odds ratio. So that's my comment on the lucky guess, the first go with CATS. And cognition were all significant predictors that improved the predictive power of Euroscore. And this just shows the AUC impact, improving the area under the curve, which is a predictive metric of Euroscore 2 with a frailty measure added. This is busy. It's my grad student, current grad student, Ryan Gaynor, who I think some of you in Nova Scotia are familiar with. Again, looking at the FACT tool, really it's the same data set. And let me just say both of these studies are combined studies between New Brunswick and Nova Scotia. So that's a grant that we held together with the Canadian, with the CFN, the Canadian Frailty Network. And we see that activities of daily living, particularly that dimension of fact, had a negative impact on the improvement change in a health-related quality of life index at 6 months. So this is the gold. This patient and many patients who are older and living with some frailty really are not that concerned with mortality. They're concerned with quality of life. They're concerned with functional independence. And so we've got to stop measuring things they don't care about. So we'll have a very successful operation. We didn't have mortality. We didn't have 30-day mortality. We didn't even get that many major complications, but they're miserable at 6 months. So we've got to be measuring at 6 months in a rigorous fashion what's going on. And all these patients were followed up by phone call or in person at 6 months. And we saw a negative deflection in health-related quality of life at 6 months in those that were ADL frail. And the same is true of another very cousin of that, which is the EQ-VAS. It's a general health-related quality of life measurement. And so those were negatively impacted. So just to bring this home, if you're ADL frail and we don't do anything differently about how we care for you, you're very likely to have a negative inflection in health-related quality of life measures. And then we went on even more strongly to look at dependent living status versus independent, and that was negatively predicted by ADL frailty. And treatment decisional regret was a strong signal at 1.83 for ADL frailty. So this was really gold for us. We're just getting this together for publication, and again, it's combined work between New Brunswick and Nova Scotia, of which I'm very proud. Others have shown long-term negative impact of frailty, and this is just an example. I won't get into detail because I want to have some time for discussion. So what to do with this information, and what it was to Rakesh Arora, and not incorrectly, his mandate, and he's pursued it aggressively and to some degree successfully, is to defrail the patient and get a better outcome. But to Greg and colleagues, it was to make a better decision where the patients got to contribute to decision making. This is just quotes from some qualitative work we did a couple of years back in preparation. And the one quote at the bottom left has been said to me. This is from an ICU nurse. If I had known what this was going to be like, I would have never gone through it. So we really, I think, as practitioners, want to avoid decisional regret. Informed consent in surgery is woefully deficient, and many papers show that comprehension is terrible. Mishra and cardiac surgery, importantly for this discussion, showed that only 40% knew a general mortality risk, 65% couldn't name a single complication, 55% only partially understood their diagnosis. For example, I have chest pain, but no idea why, and 15% couldn't name a surgeon. As we demonstrated in a paper we published a few years back, and as you've all experienced, we're seeing patients that have an increased amount of frailty. We showed over 10 years, and this is old now, that we've got an increase in valve surgery, a decrease in isolated coronary surgery, which is less risky, an increase in frail patients. This is measured by CAT, so this is ADL frail in a very significant way, 4.2 to 10% now. And an increase in octogenarians. The octogenarian ratio has doubled, and age and frailty aren't the same, but they sure live together. The Institute of Medicine asked us 20 years ago now that all information flows through the patient and family, that the patient's the source of control, that care is patient-centered, and care plans take patient values and preferences. And we know how to do this, which is shared decision-making, a formalized approach that prompts the patient to really engage with the practitioner. And I would argue one of the failures of this is it's too late when the surgeons come in to talk to you. We have to get the whole healthcare team, our cardiology colleagues, and our allied medical professionals who are interacting with the patient as they're coming into the cath lab and getting worked up, and even the family practitioners, if we could get some effective reach out to them to get the patient activated, to ask questions, and to get the patient to realize they have choices. There's always more equipoise than you think. This is a decision aid that we developed. The decision aid is an excellent tool that helps shared decision making. It's not the only thing. I think you need some shared decision making training. You need to make some measurements of effective shared decision making, which we can get into discussing, to make sure that you're doing the right thing. And this is an individualized decision aid. So we take it's a parsimonious model we developed that includes frailty. This is CATS frailty as a predictor. And now we are putting on outcomes that focus group qualitative work told us by previous patients what they want to know about. So this is a 66-year-old man with diabetes, hypertension, and triple vessel disease. This is an individual decision aid, not a generic decision aid. And we display the risks in what are called Montori Dot Plots. And isn't a terrible choice, red and green. That is the most common type of color blindness, but there are a lot of few mistakes. We can print it with different colors. And you can demonstrate mortality, stroke, discharge to an institution, chance of any dialysis. It doesn't seem to make sense to us, but it's what patients want to hear about. And we can model some other things as well. And we've done a pre-post design study of shared decision-making using that decision aid and using decision-making training. And we were able to move the needle importantly on the comprehension to try to improve what Mishra had noted, and on what's called the SDMQ9, which is a measure of decisional quality. We also reduced decisional regret. So let's come back to the case for discussion, and I think this will leave us some reasonable time for discussion. The 87-year-old male whose goal was to get back to the garden, he opted for surgery, and of course this is all a good news story. He made a good recovery. He got back in his garden. So what can we do as we approach older patients who are living with frailty? I would suggest we could and should consistently measure frailty using a validated tool. There are 60 of them. I really don't have time for zealots for a particular tool, but we just ought to get on the same boat so we can compare what we're doing with one another and have some power. Refine our predictor models to include frailty as a predictor, but most importantly, to model the outcomes the patient cares about, which is, I think, functional independence at 6 months, and freedom from, they don't want to be a burden. The 80-year-old with ASCAD who's able to take care of their kids, take care of their grandchildren, for their adult children after school for a couple of hours, even if they're symptomatic as heck, they're able to do that. They're still able to drive. They may be very willing to live with a reduced life expectancy rather than risk loss of independence at 6 months once they see that number. We should engage patients in shared decision-making, which means train our staff and not just our surgeons and not just our interventional cardiologists, but our general cardiologists, and most importantly, our allied medical profession. Provide decision aids we can all agree on modeling for, and create a surgeon team approach instead of the old DIA that's a very recent revelation to us. And when there's equipoise, allow preferences to drive the decision-making. And I would tell you there's more equipoise than we think in almost every decision we make. And there's our gardener. So thanks for that opportunity. I hope there's enough time here for some good discussion.
Absolutely. Thank you, Greg, and Ansar is giving me the opportunity for asking the first question, which is great. And thank you for the kind words in the beginning. So, Greg, it's many years of work that you've showed us and sort of reflections on all that. I wonder if you could comment a little bit on, the value also of geriatricians and the clinical path, for example, that you have in Nova Scotia. Sometimes I find that we require help from others to try to help us sort out complex relationships or issues with frailty, how to assess it properly beyond the tools that we sometimes try. And I find we lack a little bit of standardization. And I wonder if sometimes the geriatricians, at least where I work now, understand really what I'm trying to get at. Because I think the patients they likely see that I'm seeing are likely very good in the spectrum of geriatrics patients they see. And so they're sort of, wow, what are you talking about? This guy's great. Right. Anyways, just your thoughts around that.
So sure, I have a couple of comments about that and some recent revelations. And, I work pretty closely with Ken Rockwood, who is a rock star, and I work pretty closely with Paige Morehouse as well. They come from somewhat different perspectives on this. You're quite right. That's a very accurate statement that the 4-5, the clinical frail scale 4-5s aren't their worry, but they're our worry. And so when you ask them to help, they sometimes shrug a little bit. And I think it's up to us to develop those tools. But when you hear Ken go on, he's quite right. He's got this long perspective. He said, in the 50s, we built big tuberculosis hospitals and trained a bunch of people to treat. It was an army of people to treat tuberculosis, like we have an army now fighting COVID. And then when there was a baby boom, we built all these IWK pediatric hospitals we don't need anymore, no offense, right? But there's no children to fill them. And what we need now are big geriatric hospitals, not really, but armies of geriatricians to take care of, what, if you look at the age demographic, I didn't include that slide, we're becoming an older population, and many of us are living with some degree of frailty. And yet we don't have the workforce, JF. I mean, you can't get a geriatrician in on every one of it. So we're gonna have to use them to refine our tools and use them wisely. And I think in my own experience, where I need the most help is cognition. I think the other three dimensions are pretty easy to figure out, but cognition is, it can be tricky. And, it's on Greg's to-do list to learn the Montreal mini cog so that, at least I can be adept at that. But you're right, we should get really some assistance from real professionals with a narrow bandwidth who know that stuff inside out to help us, especially in cognition. Thanks for the question. And, I think one of the issues will be workforce limits, how much help we're going to get.
Yeah, Greg, I think that's a great point. And JF, thanks for that question. I think one of the major issues that I run into is time and being able to adequately delve into a lot of these issues with the patient. So I often end up taking a very paternalistic approach to them. And I sort of say, look, this is what I think is best for you. And, not uncommonly, they will kind of move in lockstep with that because that's comfortable for them. They are seeing me as the proverbial expert. And as such, they see me as the person who's going to be likely to make the best decision for them or for their father or for their mother. So, I see time as being a major barrier. And then I guess my question for you is this a role potentially, much like, you have centers that have, a nurse that runs an aortic disease clinic or a nurse that runs a mitral valve center of excellence clinic. Is this a role for having a nurse that's dedicated? Look, we know that 2/3 of our patients are over the age of 65. Not an insignificant number are over the age of 70 or 80. Should these people be routinely assessed by somebody who just does this almost all the time, and then have that same person be the person who sees these people in 3 months, 6 months, and 12 months?
So that was my vision for the nurse navigator role, was to act as a decisional coach, but she got so rapidly sucked into the vortex of just getting the trains running on time that she was never able to. There's just so much work, it's so busy. So that's where we and others have hatched the idea of a team approach, so that everybody who's touching the patient is activating the patient, handing out decision aids. And the patient has time, we don't. So by the time they get to you, Ansar, for the informed consent discussion, they're kind of armed to be more like an Upper East Side New Yorker than a Nova Scotian or a rural New Brunswicker, and they're going to ask you and push you. And yourself, if you get pushed, then you slow it down and you answer the question. So I think we have to inoculate the patients, if you will, and get them to understand there's equipoise and that there's preferences to demand that get listened to. Sure, resources are so damn scarce that yes, I think we could make actually a financially sound argument for a decisional coach role in cardiovascular interventions. We could go offline and talk about why that would be financially sound. Just if you do good shared decision making, it's usually about 15% less aggressive intervention, so it pays for itself. That's hardly a great sales pitch to a group of heart surgeons, of course.
I guess the other question I would have for you is, not uncommonly do we get roped into a situation where we've got somebody in the OR and the unilateral, consensus amongst care providers around the table is, I can't believe you just operated on this patient, or that you're about to operate on this patient. And, the same refrain, kind of makes its way through the ICU and on and on and on. And, at the end of the day, we're kind of left to, hold the bag for this patient and really kind of take them through. And not to say that we're the only ones in their corner, but there is a lot of skepticism. What do you say, what's your approach to somebody who, despite, your best efforts to provide them with informed consent as to where they may be in 6 months, 12 months, et cetera, says, you know what, I don't care, I need to have something done, my quality of life is so poor? So
I do have an answer to that, which is care limits needs to be part of this equation. So you want to roll the dice on a high risk proposition. Most people want to avoid dependence. Let's put some care limits in place that that don't make this the guy in the corner pocket for 30 days. So let's re-engage the risk. And this is Claudio DeQuinzio's contribution, an anesthesiologist in our group. Can we remodel the outcome at day 3 and do informed consent again? And shouldn't we do that every 3 days? That's a pretty radical shift, but it's not incorrect. So I think it's valid to go ahead with the Euroscore risk of 35% with care limits in place. Of course, you end up looking terrible when Ansar comes along and report cards you with CAI, but I mean, we've just got to make allowance for the fact that we're doing these high-risk cases at the behest of the patient. I do see in the chat from Susan Morris, I just want to bring that up, that I think nursing staff are underutilized in this equation. Developing tools for nurses makes sense. So thank you, Susan, and please reach out to me, because we're very keen to create a team approach, and we'll certainly happy to share any tools that we have in terms of the other chat.
So Greg, maybe you want to just in our last minute, just speak to, what do you think? So, I mean, nationally, we are in the throes of, you and I and Rakesh and a few others, after a workshop that, we recently presented at the CCC virtual, we're in the throes of trying to get a sense for what frailty uptake there is across the country, how people approach this. What do you think, honestly, is like the next step? Because we've been beating the frailty ban now for almost, as you say, 15, 20 years. I mean, the Circ Pub, can't believe it's already, we've passed the 10-year anniversary of the circulation pub. What would you like to sort of see as being next steps for, actual traction?
I think pan-Canadian's too much to wish for, but if we can get multiple centers, and it seems like Manitoba's keen, you guys are keen, we're keen, and there's a couple of other centers, Ottawa, that are keen to measure frailty the same way and start deploying decision aids and start engaging. And we're right now working hard to develop a shared decision-making training tool that we can administer to both our nursing staff and the allied health professionals who interact with those patients, as well as to professionals, both cardiologists and cardiac surgeons. Get that training out, get some frailty measurement going on, and work together to cobble together some form, a Mark I of a decision aid, or I guess we have one, but maybe a Mark II of a decision aid that uses a better frailty measurement. We have the data now on the shop room floor to create the coefficients, and get those decision aids out into vulnerable patients' hands. And I would say that's anybody over 65, and just do a pre-post impact study on that and start to make some noise. I think we have an opportunity in Canada to lead the way in shared decision making. It's all been done and all been shown, but it's all the systematic reviews show there's absolutely no uptake because there's no time. So this is a classic implementation science problem. And again, Susan Morris's comment is the nurses are underutilized. Let's use them. Let's get the tools out ahead of us. It can happen. We're now recording informed consent discussions, believe it or not, with surgeons permission. And I'm so excited to leave here and go record an informed consent discussion between one of my colleagues and a patient who's having surgery this afternoon. Well, that's going to be a very rich informed consent discussion in terms of how much it hits all the bells of proper shared decision making. It absolutely can't, right? So there's in a sense the fruit is hanging low, but it's a hard train to move because the time pressures, and I think hitting on that team approach, I'm quite optimistic about it.
Yep, thank you, Greg. And Ron, you've made some good points on the chat as well. And I think those are, I mean, everyone's got a role, from family docs to cardiologists to obviously to us. But I think at the end of the day, we need all the information before you can truly make have an informed conversation. Greg, thank you so much for your time. For making the effort to present to us. I think you're a leader in this field and have been for years and years and years. And I think JF and I have carried on some of the frailty torch here as a result of that, as have others across the country. And let's continue to collaborate as we move forward and try to obviously improve the care of cardiac surgery patients both in Nova Scotia and New Brunswick. So
okay.
Greg.
And thanks, Ron and Rob, for those comments. And thank you, Ansar and Jeff, for this opportunity. And again, if the informal opportunities to get together with your group and talk about this, if we can do some focus groups with your team, we would love that. Thanks very much.
Thanks, Greg.
Cool.
Thank you, everyone.
Thank
Last session next week with JF presenting on the year in review and what to look forward to in 2021.
COVID vaccine.